And I'd like to call up our first speaker, Professor Stephen Overman from the University of Washington. Professor Overman is going to give us a presentation on patient perspective pain paradigm facilitation of integrated team care, and I'm sure he can say that without tripping over it. So, Stephen.
Dr. Brown, thank you, and thank you all for coming and giving me the opportunity to present this morning about work that I did as an independent consultant for a regional health consortium of Native Alaskans. But before I do that, I want to just look at my notes and bridge this morning's conversation, which was so wonderful. And I noted that Danny said that understanding the problem differently changes the intervention, and certainly this is true for individual patients. Truly understanding their problem changes how we care for them. And then Anthony described consumer-driven care, and I've used the term patient-driven care a lot. But and engagement's important for both. But there's a difference. For patients, at different phases in their illness, they're less or more able to truly engage, and we need to remember that difference as it relates to patient versus consumer. So finally, Danny called for real-world solutions, and so that's really what I'm here to talk about. This is a very real-world, boots-on-the-ground activity, and stuff that I developed over years in practice. So to try to keep on time, we got it right here. Let's see. Yes, that's me. I'm a rheumatologist. I was medical director for a health plan, a Medicare risk plan years ago. I consult with and advise Kinsai, which is a data platform, data integration, machine learning company. There's an opioid epidemic in the United States. In 2016, more than 130 people in the U.S. died every day after overdosing on opioids. 2 million misused opioid prescriptions for the first time, and over 2 million had an opioid use disorder. In 2017, a public health emergency was declared, and a 5-point strategy was implemented to combat these staggering statistics, and the fifth of these 5 was better pain management practices. I worked with a primary care group that had already implemented an opioid reduction program and started medication-assisted treatment for persons with opioid use disorder. Happy to describe those more for those who don't understand what that means. But they were unsuccessful in sustaining an integrated pain program for several reasons. First, patients were reluctant to be seen in the behavioral health clinic, since this implied that their pain was a mental health problem. Second, patients were found it was the medical director who talked to me. In fact, we heard about language earlier today, who said to me, we need a new language. And she described how providers and patients frequently had conflicting ideas, language about the cause and the treatment of their pain. Finally, self-management and coaching and care management were provided to a limited degree in the primary care clinic because they couldn't scale due to staffing and billing reasons. I was hired as a consultant to develop an integrated pain program. After out-of-state site visits and broad stakeholder inputs, we developed strategies to try to deal with the 3 problems I just mentioned. I think I'm hitting the wrong button here. Did I just go backwards? There we are. First, to counter patient adherence, we arranged for behavioral therapists to see patients in the rehabilitation department. They joined a pain specialist, a nurse, and a physical therapist for a team evaluation. To change communication, I introduced the patient perspective pain paradigm that created a framework for patients and providers of different backgrounds to discuss pain from the patient's point of view. Thirdly, finally, to expand the patient coaching and care management, we used the behavioral health department's established procedures to develop financially viable pain care services that integrated around the primary care provider's office. Having a patient perspective means comprehensively understanding their most common questions and fears. What is the cause? Patients frequently reveal stories of past injury, fears of cancer, or missed causes of their pain. What is the treatment? Most patients have tried many therapies, but few have looked for synergies among integrated therapies. Most have not achieved confidence in managing their own care. What is my future? Most perceive a future of increasing pain and disability and more social isolation. Do you think it is all in my head? The deepest distress for many is feeling they aren't heard or believed. Pain paradigms help guide our thinking around a problem or an issue. There are a number of paradigms in pain. Pain duration is most commonly used paradigm, which leads us to think or talk about pain as acute if less than 3 months or chronic if greater than 3 months. Some paradigms direct medication prescribing, as did the 1986 WHO pain ladder for cancer treatment, which directed providers to increase analgesic medications in a stepwise fashion. More recently, pain has been categorized based on presumed pathophysiology. Nociceptive means pain from injury or inflammation. Neuropathic means pain from damaged nerves. Nervous system sensitization means pain from neuroplastic changes within the nervous system. One level of care paradigm is called stepwise care, which is a strategy for organizing a care system, escalating treatment, sophistication, or intensity based on the patient's severity or complexity. But none of these paradigms directly interpret a patient's experience or help them self-assess or integrate their care. So I developed the 3-part patient perspective pain paradigm, help me come up with a new phrase, to help patients and providers evaluate pain and create an integrated care plan. I believe this paradigm is relevant to every patient or person with pain persisting after their acute care. Patients commonly are aware of activities and associations they believe are the cause of their pain. And so these are considered as part 1 of the 5-component pain evaluation. Increasing patient self-efficacy leads to better outcomes. So the second part of the paradigm is the 4 phases roadmap, which helps patients see a path to improvement. Patients' participation is critical to outpatient pain management. So the third part of the paradigm is For You Care, a patient engagement strategy that helps integrate active therapies with their standard care. Let me detail these each a bit further. The 5-component self-assessment can lead patients to self-care strategies. First, patients usually complain about movement or activity aggravating their pain, stating, "I injured my back, lifting and movement still aggravates my pain." Therefore, self-awareness in order to prevent re-injury and then optimize function is a critical first step. Second is inflammation symptoms are common, but signs are frequently not detectable on exam. A person might say, "I have morning stiffness, the 3 ibuprofen seems to help." Undetected inflammatory conditions are common in patients with fibromyalgia or chronic back pain, especially if that back pain came on at an age less than 40. It may also be why diets are so commonly noted to help pain, which can affect inflammation. The peripheral and central nervous systems transmit pain signals, but if either short circuits, it can become the source of the pain. Grimacing, a patient may say, "It hurts to touch my skin." This is allodynia, and it may reflect peripheral nervous system sensitization, such as is seen in shingles or post-herpetic neuralgia, or in fibromyalgia, which may occur after a variety of events, including adverse childhood experiences. Individuals can be taught how to desensitize this kind of pain and to improve their sleep. The stress systems. We all talk about stress. This includes the adrenal axis and the autonomic nervous system. Patients become aware that their fear and frustration aggravate their pain and frequently notice bodily changes such as cold hands or heart palpitations. Some find that meditation and biofeedback help their symptoms and their pain. Finally, the fifth part is cognition and emotion, which I put together. Traumatic memories can worsen pain, and patients can learn to change their fearful thought patterns. After helping patients understand the potential components of their pain, and I would say there's always a bit of all five components in all people's pain to a greater or lesser degree. The second part of the paradigm is to help them see a way out. I described the 4 phases of my patient's journey in a book that we wrote. For my own guidance, I looked at those phases and developed one overriding goal for each phase of that person's journey. The getting sick phase is the crisis phase of not knowing what is really going on. Listening closely, reviewing 5-component diagnosis, and offering crisis management are the initial steps to help an individual find hope. The being sick phase comes after crisis is stabilized and new therapies are being integrated. A coaching strategy is needed to help an individual feel more confident in managing their care. The grief phase occurs when, despite all of our best efforts, pain or illness persists and a feeling of failure and loss occurs. Understanding that this grief is normal and is different from depression can help a person move through it and find acceptance. Finally, with acceptance, an individual may achieve wellness, and this commonly occurs when they're able to turn outside of themselves through time in nature or in helping others. The third part of my paradigm is a personalized care plan. While my goals are to move a patient from passive therapies to confident, self-directed care, this process takes time. When discussing this, I commonly draw 4 columns on a piece of paper. The first column says, "For you," and lists further assessments and advocacy that I will do for them. "To you." These are the therapies that summarize passive things that they get. Medical treatments, touch therapies, invasive therapies of different sorts. Then I draw a line down the center and suggest that for each therapy already listed, they need to implement at least one self-care or outreach activity from the 2 columns on the right. You for you. These are the mind, body, and spirit type activities, of which then I list a menu of choices for them to pick from, where they start, where they are, and where they want to go. In the right column is you and others, family, friends, work, and past traumas. Sometimes the relationship with things in the past is the deepest anchor that we have to try to let go of. So the pilot program steps that were important were first building the EMR templates for referrals and scheduling, completing a pre-visit care management phone call and 1 clinic visit to complete screening questionnaires, setting up appropriate billing procedures for team evaluations and for the telephone care management, developing interprofessional agreement regarding the appropriateness of continued opioid use, and that was an ongoing conversation. And finally, introducing the patient-perspective pain paradigm to facilitate patient care, interprofessional discussions, and shared decision-making. So I offer 3 conclusions from developing this pilot pain program. First, behavioral health perspectives, services, and systems are critical to integrative pain management. Second, the PPP supports multi-component assessments and helps patients gain confidence in the very important role they must play to achieve pain control and to achieve a more meaningful life. And finally, modeling patient language or perspectives helps integrate pain care between multiple disciplines and around the patient and for the patient. Thank you.